Patient evaluation. The preoperative or pretreatment assessment should focus on the following 4 areas. Analysis of the physical attributes of the ear or ears. Emotional and mental preparation of the patient and family. Selection of the appropriate surgical technique to address the deformity. Determination of the optimal anesthetic and patient position. During a meticulous preoperative evaluation of the anatomy, the surgeon should assess the following. Degree of antihelical folding. Depth of the conchal bowl. Plane of the lobule and deformity if present. Angle between the helical rim and mastoid plane, and quality and spring of the auricular cartilage. Specific preoperative evaluation. Low self-esteem, general lack of self-confidence and social isolation are amongst the reasons why parents of affected children or affected adults decide for otoplasty. In a study by Sheeran et al., children with prominent ears were evaluated by a psychiatrist before undergoing surgical correction. An increased tendency towards depression, lower achievements in school, lower self-esteem, and socio-communicative problems in school and at home were observed. Schwentner et al. Interviewed patients before and after otoplasty regarding their pre- and postoperative emotional state, using a standardized questionnaire. The results showed an improved attitude towards life, increased courage to face life, and better self-confidence among the patients, with no difference between male and female subjects. Horlock et al. Stated that 74% of adults and 91% of children reported an improvement in self-confidence resulting in improved quality of life. Naumann described a useful algorithm pre-otoplasty for the evaluation of the ear and the planning of the procedure, recommending that attention should be paid to the following parameters. Helix mastoid angle, greater than 30 degrees. Helix mastoid distance, cranial helical rim at the level of the cavum conchi lobule. Hypoplastic antihelix and antihelical folding. Conchal hyperplasia, cavum conchi. Position of the lobule. Isolated changes at the ear, coloboma, Darwin tubercle, auricular appendages. Cartilage consistency, soft, easily pliable cartilage. Thick, stiff, poorly pliable cartilage. First intervention or revision. Tendency to develop keloids. Age of the patient. In addition to a thorough history and physical exam, preoperative photos and measurements are imperative. A frontal view, right and left 3/4 view, right and left profile views, a submental vertex, and posterior view are a standard photo set. Taking certain medications, as well as using tobacco products and certain herbal supplements, will need to be ceased in the weeks prior to otoplasty. Timing of surgical intervention. One of the biggest challenges in otoplasty surgery is determining the proper age to undergo surgery. Despite being a benign condition, emotional trauma and behavioral problems, lack of self-esteem, and permanent damage to body image can be seen in children with protruding ears. These problems remain the prime reasons for performing surgery at an early age due to peer ridicule in primary school. Realizing this, the most opportune time to operate on most deformities is the preschool age. As 85% of ear development is complete by age 3 and the ear is fully developed at 7 to 8 years of age, there is little reason to wait for correction. Reviewing the literature shows surgeons performing ear surgery as early as 9 months of age, but most surgeons agree that otoplasty can be safely and effectively performed on 4 years old. We normally consider patients aged more than 3 years to be candidates for surgical intervention when they are motivated for repair and demonstrate concern for the deformity. By 3 years of age, the ear reaches approximately 85% of its maximal dimensions. Ear width reaches its mature size at around 7 years, and ear length matures at around 13 years. Immaturity and lack of desire can significantly interfere with postoperative compliance and ultimately with results because postoperative splinting plays a significant role in repositioning. Recent studies have examined the ideal timing for otoplasty and suggest it should be performed before 4 years of age, as otoplasty has been shown to improve quality of life in children, which has been validated through both the Glasgow Children's Benefit Inventory and the Pediatric Quality of Life Inventory. Assessment should focus on age of the patient, as prominent ears typically do not affect a child's self-image until they are older than 5 or 6 years. Surgery is best performed prior to this age. Other authors, e.g. Ballo and Melisai, Gossain and colleagues, concluded that growth of the ear is not arrested following otoplasty. For me, I did not observe any visible disturbance or growth restriction in my otoplasty patients after a considerable period of follow-up. Patients often present as referrals from pediatric primary care doctors, or late as adults seeking otoplasty for aesthetic purposes. Caution should be granted in patients with unrealistic expectations, those who are unable or unwilling to cooperate with postoperative care. Also, surgeons must be alert to the occasional adult who magnifies the severity of a small defect or who sees serious deformity in ears that most others would judge as being normal or symmetrical. The main disadvantage of the surgery before age 5 is postoperative difficulties dealing with the dressing. The procedure is best performed when the auricle has reached maturation and the child is old enough to cooperate with the postoperative care. It must be kept in mind that correction before age 5 may complicate the postoperative course when the child, even if not intentionally, pulls apart the bandage and potentially disrupts the repair. Conclusion: the appropriate time for corrective surgery should balance auricular growth, cartilage pliability, psychological burden secondary to the auricular deformity, and patient maturity level. In the golden window between ages 4 and 6, these elements align, thereby allowing optimal execution of reconstructive techniques to improve the cosmesis of the ear. After prominent ear correction in patients younger than 6 years, Mustard demonstrated a 1.8% recurrence rate at 10 years after the procedure. However, patients older than 6 years at the time of surgery experienced a 30% increase in relapse rate. Pearls. In situations where the main deformity is conchal excess, it doesn't make sense to employ a technique designed to create an antihelical fold. Pinning the conchal cartilage to the mastoid fascia with sutures, furnace procedure, has not proven stable for many surgeons and presents other aesthetic problems, such as constriction of the external auditory canal. The procedure I prefer for conchal bowl excess was described by Davis, and involves removing the excess conchal cartilage to reduce the bowl itself. So far, no conclusive evidence is available with regards to the age at which the growth of human auricle is completed. There are numerous anthropometric studies showing that up to 90% of the auricular growth is already completed at an age of 11 to 12 years. 85% of auricular growth is completed by age 3, and 90 to 95% of adult size is achieved by age 5. Procedure. From Diefenbach in 1845 to Fritsch in 1992, various corrective ear surgery techniques have been developed. Each technique has advantages and disadvantages, such as the techniques using Mustard sutures to redesign the antihelix, developed in 1962, and the techniques using furnace sutures for conchal scaffold fixation, as described in 1959. Treatment of prominent ears includes non-surgical as well as surgical methods. Surgical methods can be divided largely into 2 groups: cartilage cutting and cartilage sparing. These techniques are often utilized in combination. Non-surgical correction. Non-surgical correction of prominent ears usually have mixed results, but recent advances have made neonatal treatment more predictable. Recent research has shown that newborn ear deformities are extremely common, affecting up to 30% of all full-term children. Unfortunately, only approximately 1/3 of external ear deformities self-correct. This leaves many newborns candidates for correction of deformities of the external ear. Several reports, mostly in the Japanese and British literature in the 1980s and 1990s, have shown that molding the deformed ear, especially if started within the first 3 days of birth, can lead to excellent correction. Excellent results were reported by Tan et al. When auricular molding was started within 3 days of birth and continued for up to 6 months. Delay of treatment yielded poor results. Tan attributed the loss of cartilage pliability after birth to decreasing levels for circulating maternal estrogens, which are highest in the first 3 days after birth and decrease to normal levels by 6 weeks of age. Matsuo et al. Also reported no recurrence after 6 months when the prominent ear was corrected with surgical tape within 3 days of birth. However, results were poor when the taping was started after this period. In early 2012, Van Wyk et al. Prospectively studied 209 ears in 132 babies treated with ear splinting using the commercially available earbuddy system. They noted fair or good results in 66.7% of those who followed up if splinting was started before 6 weeks of age. It should also be noted that these techniques are best suited for reshaping the antihelical fold, but do not reliably treat a deep conchal bowl. External ear molding in the newborn takes advantage of circulating maternal estrogens, which renders the cartilage of the external ear somewhat pliable until those estrogens disappear. The estrogen levels are highest in the first 3 days after birth and decrease to normal levels by 6 weeks of age. At this point, the structure of the ear is difficult to change without surgical intervention. The Earwell Infant Ear Correction System is a device that allows for anatomic correction of most commonly seen types of deformities of the external ear. In order for best results to be obtained, the device should be placed no later than 2 weeks after birth. A typical treatment course averages 6 weeks. However, if treatment can be initiated within the first week of life, treatment time can be shortened to 2 weeks with 95% efficacy. Laser-assisted cartilage remodeling, LACR, is based on the temperature-dependent characteristics of cartilage. Cartilage biomechanics are temperature-dependent, and temperatures between 50 and 70 degrees Celsius induce stress relaxation leading to gross morphological changes. The ideal wavelength for cartilage reshaping is 1540 nanometers because the penetration depth matches the thickness of cartilage, thereby allowing for homogeneous heat generation. A systematic review of 7 clinical series 22 utilizing LACR to correct a prominent ear revealed a similar degree of correction when compared with conventional techniques. Surgery continues to be the main therapy to correct the protruding ear.